welcome to SME's Symposium for June. So today's webinar is going to be on what to expect when working in the NHS. Let's move it forward. Okay, so what we do is we do monthly webinars. I hosted the last one, so this is my second one with you guys now. So it'll be one webinar every single month, and the idea is that we're dedicated to keeping you up to date on relevant and important medical topics. The topic varies every single time, and in these symposiums we have medical professionals join us, and they are the ones that conduct the presentations. And I am here for all the rest of the work, all the rest of the hard stuff. For these webinars, everyone is welcome, so it doesn't matter if you're an SME student or not. Feel free to join, feel free to share our links with everyone. And this webinar is free, guys. So, like I said, everyone should join. And there is a question and answer at the end of the presentation, so please make sure you wait until the presentation has finished with our guest speaker today, and we'll have a question and answer, and I'll also be there to answer a few questions for you guys as well. So today's speaker with us today, we have Dr. Simren Dhaliwal.
Yeah.
Hi Simren, how are you?
I'm good, thank you. How are you?
I'm good, thank you. The last time that me and Simren met, she was still a student. And
yeah,
now,
that's actually very true.
And now you're a doctor, we're meeting on a screen, which is horrible.
That's very crazy because of COVID.
Literally, yeah. So hopefully I'll get to see you soon. You know, I owe you drinks. You know,
yeah, definitely.
Well. So hopefully we'll meet each other very soon. So I will just carry on. So yeah, so today we've got Simren Dhaliwal with us. She is a Foundation Year 2 doctor at Kingsmill Hospital, UK. She's an international medical graduate from Trachea University in Bulgaria. She will be conducting the presentation, and I'll pass it on to her very soon. So this is the event program. As you can see, I've taken the first few minutes to introduce myself and introduce to you guys what's happening today. Simren will take over from me, and she will do the presentation. Hopefully she'll finish around 7 o'clock, maybe a little bit earlier, maybe just a few minutes afterwards, and then we'll start a question and answer. Before I pass this on to Simren, I just want to say, guys, please wait until after the question and answer is done, because I will be doing the lucky draw. We offer scholarships, as some of you students might know or might have emails, and I've got everyone's names with me. So I will be doing a lucky draw for 5 lucky students, and I will explain that in detail after the presentation. Let's focus on that first. And then I will also have just a few other things to kind of pass on, some information to pass on to you guys. So yeah, so without taking any more time and wasting any more time and making you guys bored, I'm going to pass it on to Simren. She will start the presentation.
So I'll just introduce myself with my thing. So hi guys, my name is Simren. I'm one of the graduates from Trachea. I was actually the first batch in that year. So I've got like a presentation ready for you guys and all of the tips that I wish I knew when I was moving over from Bulgaria to England. And then at the end, you guys can ask me any questions if I've gone too fast or if there's anything that I didn't cover. But yeah, so let's get started. The content we're going to go through today is the shift patterns. So one thing that we don't really realize, and they kind of learn this when they're at med school, is the different type of shift patterns you have to do, and your role changes depending on what your shift is. So we'll go in detail on that and talk about your duties, how to admit a patient in, what you're expected to do. So just a bit of basics so that when you guys start, you have an idea how to write a discharge letter and how to write a referral letter. So this is not only really useful for you guys for when you're starting to work, but this is also really useful for you that have to write the OET, which is an English exam that you guys have to do before you can, start working in England as well. So this kind of covers them both. So I'm going to go over some abbreviations with you guys that we use a lot in the NHS, and I've kind of used them throughout the presentation. So HX stands for history, so your patient history. This includes why did the patient come here? What did they present with? SX is for symptoms. DX is for diagnosis. So you can say, what you think this would be, what you definitely think this is, you can use DX for that. CX for chest, CXR, sorry, for chest x-rays. Issues is this triangle. I couldn't get my triangle to be small enough, I'm really sorry, but I'll explain to you when you use this triangle. PT is patients, DW is discussed with, or a discussion that you may have with another doctor from another department, or even another colleague of yours, and BG is background, not Bulgaria in this case. So the shift patterns. So a normal working day is NWD, and this is an abbreviation they use a lot. So your normal working day, if you're in surgery, is 8 till 5, but if you're in medicine, it's 9 to 5. And if you're in orthopedics, depending on your hospital, majority of the time, orthopedic doctors start at 7:30. So that's currently what I do at the moment. I start at 7:30. And if my team is being on call, then I'll start at 7. Then you have your on-call shifts, which are from 8 to 8:30. So when you're on call, you're not ward-based at all. Your primary job is to be dealing with A&E and any referrals you may receive from them. You also will deal with referrals from GPs, for example, that will ring you up. For example, let's say you're on call and you're in general surgery and you're working as an F2. In some hospitals, you're expected to take the referrals from A&E, and you're expected to take the referrals from GPs. So GPs may ring through switchboard, and then switchboard will connect them to your phone, or they will bleep you, and they'll say you have a phone call, and then the GP will be like, you know, I have a patient who's got, I don't know, right lower abdominal pain. I think this might be appendicitis. And then before you even accept the patient, you want to make sure you ask all the relevant questions. So you want to take a detailed history over the phone. You want to ask the GP, when did the symptoms present? How long have they had it for? What are you concerned about? What's their past medical history? And you take all this information down, and then you decide whether you think it should be, you know, whether we should accept it or not. If you are, you know, sitting on the fence about it, you're not really sure, or you want to discuss with your senior, you're completely within your rights to say, can I ring you back? Speak to your registrar or whoever's above you at the time, and then you can have a chat with them, and then you can either ask the GP to ring you back or you ring them back. Or if, you know, your registrar is in theatre, for example, you can say, actually, can you just come to send the patient to A&E, and, you know, we'll see them there. One thing you got to remember is GPs are limited by the amount of investigations they can do. So sometimes they can't give you all the answers. Like GPs don't have access to bloods like how we do in the hospital. I can take blood from a patient and within an hour I'll have the results. GPs have to wait a couple of days sometimes, or even a day, because of their lab isn't inside the GP practice. So just be mindful when you're on call and the things you ask for. A night shift, so that's from 8 in the evening, and then you'll finish at either 9 or 8:30, it depends what department you're working in. And over the night, your job, again, so you're on call, your responsibilities are admissions if you're in surgery. Even if you're in medicine, you'll be on the acute medical ward, where you'll be involved in taking referrals from A&E, which a reg will normally do, and then you'll go and clerk the patient, and we'll go over how to clerk. But you could also be a night doctor working on the wards, and so your main job and sole responsibility is to keep everyone alive, and, you know, to make sure that there are no issues that happen overnight. If someone has a heart attack or whatever, you need to make sure you're there so you can prescribe things. But then you don't, you know, get trapped into doing jobs like writing a discharge letter at 3 a.m. in the morning. That's not your job. So you just need to make sure that you first find out what your role is when you're on a night shift. So if you're the on-call doctor or if you're working on the wards. And then twilight shifts they're interesting shifts. So depending on what department, so if you work in medicine, you may start at 2:30 or 11, and you'll tend to work to about 11 at night or midnight, depending on the hospital. If you're in something like orthopedics or surgery, your twilight shift will tend to start between the hours of 5 and 4 in the afternoon, and you'll end at midnight. And this is to bridge the gap between the on-call in the day and the wards that will finish at like 8 or 5. So you're still there when the night doctor comes. So your aim is to help the night doctor to deal with the ward stuff. And then you go home. And then after midnight, the night doctor is by themselves. So on-call and acute, we've already gone over that. Night shifts, we know that different for each department, and on the weekends there's no consultant ward round. So every day in most departments you have a consultant-led ward round. Unless you're in orthopedics, that's different. But in medicine and in surgery, there is a ward round that happens every day by a consultant or a registrar. On the weekend, you don't see every patient. So on the weekend, you'll only see patients that need to be seen. So what will happen is you'll make a list of patients and you'll say, okay, gentleman in cubicle number 3, he needs to be seen because he's really ill. You know, we're concerned that he may have, I don't know, like, he's got COPD exacerbation and he's not responding very well to the antibiotics. We're concerned he might have an increase in oxygen need. He needs to be reviewed over the weekend. So you'd write his name down to be reviewed for the weekend. But in surgery, every patient gets reviewed on the weekend just because it's a surgical problem. So they need to be seen post-operatively or pre-operatively. But in medicine, how it works is you yourself with your team would make a judgment call of which patients need to be seen, which patients don't need to be seen by a senior doctor. And then a consultant will come round and he'll cover multiple wards, and he will come and be like, okay, you'll be like, hi, I'm the junior doctor today covering this ward or this ward, because you'll tend to cover multiple on the weekend. You won't be covering one. And he'll be like, okay, do you have the list ready? And you'll say yes. And then you'll go through all the patients, prep the notes for them. You don't know when this consultant's going to come round. Sometimes they may come at like 3 in the afternoon. Sometimes they may come at like 11. They tend to come before 2 p.m. is the main thing, because they've got to jump around loads of other wards and they like to go home by 3. But that's generally the gist. And that's something I wasn't aware of. I didn't know that on the weekend there's not a consultant-led ward round. So that was interesting. So what are you expected to do? So carrying out all the ward jobs. So this will be things like you'll do a ward round first. And in the ward round, what will happen is you'll go around with a consultant and a registrar, or sometimes just a consultant. And on some days, it'll just be yourself and maybe another like F2 or F1. And you'll go see the patient, you'll prep the notes. So we'll go over how to prep the notes. You know, you'll write everything down, you'll go through the bloods, you'll go and see the patient, you know, you'll talk to them about any updated results that they've had. You'll ask them how they're feeling, if they've been eating and drinking well, have their bowels been opening? That's a really important question. Patients become very constipated in hospital, and that's something you need to be on top of. Ask them if they've got any new concerns, if they've been having any medication, how have they been responding to it, anything that they're worried about, or any significant events that may have happened over the night while you were not there. And then, you know, you'll write this all down, and then you may say, okay, we're going to do bloods on him, or we're going to ask so-and-so to see him. So we'll write referral, and that will become your jobs list. So you'll write it down in the patient plan, so it's in the notes, and then you'll also write these jobs down in your handover sheet. So, you know, gentleman in cube 3 needs bloods, gentleman in cube 6 needs a CT scan, and you'll write these all down. You don't do them whilst you're on the ward round, you'll do them at the end. Then, you know, completing tasks, that will be like whatever the jobs are that you need to do to carry out the plans. You want to make sure you're updating family members. That's really important. So one big complaint that comes through a lot throughout NHS is that family members feel like they're not updated very well. And this is particular within the elderly population. So you want to make sure you're speaking to the right family members. Whenever you speak to a family member, when you obviously introduce yourself over the phone, so you'll be like, hi, I'm one of the junior doctors ringing from, you know, whatever hospital you work at. I'm one of the doctors dealing with, let's say, for example, John Smith. I just want to confirm that you're the daughter. Can you please confirm his date of birth? That is so important. And in England, they really stress on that. They want you to check first that you're speaking to the right person. So asking them simple things like, can you confirm the date of birth? Or can you confirm their line of address, if it's a friend maybe? Just so that patient confidentiality, you're not giving information that shouldn't be given out to certain people, but always take the patient's consent. If there's a situation arises where the patient doesn't have capacity, that's when obviously you take your judgment call as a doctor. You still contact the family member, you still ask the right relevant questions, and you state why you're ringing, and you say, because Mr. John doesn't have capacity at the moment, he's a bit delirious, this is why we're discussing this with you and updating you, just things like that. And then obviously everyone's favorite thing, discharge letters. So we'll go over how to write that. And obviously we've talked about if you're on call, your role is slightly more different. So you're not going to be joining any ward rounds. Your sole responsibility is dealing with new admissions, updating the list, and then out of hours, which is anything out of 5 p.m. Onwards until 8 a.m. in the morning, weekends and bank holidays included. Then if you are on call, your job is to manage any sick patients on the wards if you don't have a twilight doctor present. I know that's a lot of information, but just as a gist, depending on what your role is, depending on what your shift is, your role will change. Just be aware of that. So getting to grips with how to work on the ward, I'd say, is the most important thing. And then on call, kind of, you find your feet. So how do you write a ward round? So the first thing you do is you write WR at the top of the page or wherever you're writing the page, and that stands for ward round. And then you'll write the name of the person conducting the ward round. So even though it's you that's writing, the doctor that's actually conducting the ward round, so be it the consultant or the registrar, their name will go at the top. You can write your name next to their name as well if you would like, but I tend to just sign it at the bottom. So you'd write, I don't know, let's say we're doing a ward round with Dr. Cooper. So you'd write ward round, Dr. Cooper, and then on the side, you'd write the time and the date. That is so important that the time and the date is written there. So many patient notes go missing. So you want to make sure all of that's there. Then you're going to list their issues. So this is where our triangle that I showed you guys earlier in abbreviation slide. You're going to put the triangle sign. So issues is anything that the patient has come in with now during this admission. So let's say on admission, they've come in with a right lower iliac fossa pain. We did a CT scan. We found out they had appendicitis. So how would you do it? You'd write, you're seeing them, I don't know, the next day in the ward. So you'd write ward round, WR, Dr. Cooper, or if he's a surgeon, it'd be Mr. The date and the time on the side, on the left-hand side. Issues would be our triangle sign, and then we'd write appendicitis because we've confirmed the diagnosis. And if there's a list of diagnoses, like, I don't know, the patient might have appendicitis, and then they might have had a PE, so pulmonary embolism, you'd write that next to it. Then you'd write the news score, which I'm going to talk to you guys about what that is. Then if this is the first time you're seeing the patient, you're going to write a background. So you put BG, and then all their background. So this is basically any past medical history. So they've got type 2 diabetes, or they've had previous PEs, so they're on anticoagulants, or, they have Addison's disease, you'd write that underneath. And then you'd start to write anything new. So let's say you asked the neurologist to see this patient yesterday, you wrote a referral, you'd write neurology review noted, because you would have read the entry by the neurologist. So whatever your entry is, it's always got to show that you have done everything possible in the best interest of the patient. Documentation is so important because when you're writing on a ward round, that is a legal document. So if anything ever happened and you get taken to court, the only thing that will save you are your ward round notes. You talking to the consultant, doesn't count because he might not remember that when you guys are stood in court. Or you telling the nurse that, to give someone insulin that you prescribed doesn't count if it doesn't happen. You didn't write it down. So anything you do, document it, every single thing. I always write, if I've prescribed fluids for a patient that I've never met before and I've been asked to review them, I write it all down, my plan and everything. And then in my plan, I'd write IV fluids, staff nurse informed. So now I've done my bit. If the nurse doesn't give the fluids, that's not my fault. I've written and clearly stated what the plan was for the patient, and I've done my bit by prescribing them and telling the nurse, and always inform the nurse as well. So that's when you write anything new. So you've done a neurology referral, you've seen it, or a gastro referral, or a CT scan that you've read. Make sure you write that all down. Or blood results from yesterday or the morning blood results, you write that there. Then you go and write down anything you discuss with the patient. So you'd start off with patient comfortable in bed or patient sat in chair. And then you talk about, have they been eating and drinking well? What are their present complaints? Are they complaining of any pain? Are they just out of surgery? Are they telling you that they're in, their stoma bag's not working? Have we started giving them a new medication for their diabetes they feel is not working? Things like that. And then at the end, you're going to write your impression. So if nothing's changed, there's no change to the impression, you can skip this part. But if there's something new, like, I don't know, they're saying to you that they've got the scans confirm that they've got appendicitis, for example, but actually, you're going to run a few more tests because they've got some watery diarrhea, for example, or it's loose stools. You could put impression, appendicitis, query, C. diff. And that's obviously what happens when we give too many antibiotics to a patient. The bacterial lining within our gut, it obviously changes and it becomes becomes an infection. Then you write your plan. So what is your plan for today? So let's say we'll go with the story of the loose stool. So our plan would be to send a stool sample, continue IV antibiotics, IV fluids, encourage oral intake, things like that, and then sign it at the bottom. So you put your signature, your name, your GMC license, and what your position is, and that's it. That's how you write a ward round. So WR at the top, patient the ward round. So it could be you, or it could be the consultant that you're with, date and time, diagnosis and issues of the patient, the little triangle sign, what the news score is, medical background of the patient, if it's the first time you're seeing them, if we've done anything new like bloods, referrals, CT scans, then we put the actual patient consultation in, then your impression, if something's changed, nothing's changed, you ignore the impression part, straight to your plan, and then sign it. And then you move on to the next one. So admitting a patient, this is for when you're on call. So you'll get an on-call, for example, let's say you've been bleeped by A&E and they've told you that patients come in with some really severe abdominal pain and they've done some tests that show that they've got high inflammatory markers, they've done a CT scan, they're waiting for the report, they've asked you to go and see them. So fine, you're going to go down. So you're going to go see the patient, you're going to collect the notes first, read through the blood results, read a bit about what A&E has done. You're going to go in to see the patient, introduce yourself, who you are, what team you're from, why you're coming to see them. Bring all that information with you before you start talking and asking them questions. They're very scared as it is. They're in a new environment. They don't know what's going on. You need to present and explain who you are, because they would have spoken to thousands of people by this point, and they're probably fed up of retelling their story. So by reading the A&E notes, it shows that you've already taken an interest in the patient's story and you're semi-aware of what's going on, but you want to hear it from them. And you want to explain that to them kindly and in a calm manner so that they feel like they're being listened to. So the first thing you're going to say is, when did the symptoms start? So what are your symptoms? When did they start? How long have you been experiencing them for? Is there anything that triggers it? What were you doing at the time of the symptoms when they started? Is it fluctuant? Is it a constant? So remember your Socrates when you're going through that. You can't, you can use it for pain, but you can also use it for like general, when you're trying to take a history from a patient as well. So if this is a recurrent problem, what made them come to the hospital this time in comparison to previous times? You take all this information down, then you want to ask them about their past medical history. Now you can already access all this information over the computer, but by checking with the patient, it just shows that you're taking an interest in their case, but also some of the systems may not always have all the information. So you need to make sure you can gather as much information as possible from every aspect. Patients those who come to the hospital and that have a very extensive medical, medications list, they'll be very prepared and have the list with you. Ask them if you can use it for a second while you write down the drugs. You have to write down what medication a patient is on when you're clocking them in. So make sure you write that all down. Even if you're prescribing electronically or if you're prescribing by hand, regardless, you need to have a list of all their medications from home. Because if we change anything, while they're in admission, or we change anything just before we discharge them, we have to be able to update the GP on, oh, I'm sorry, I know you prescribed the patient 20 milligrams of furosemide, but while they've been in hospital, we've increased the dose to 40. We'd like to continue it post-discharge. Could you please review it 2 weeks after? So then they have an idea of, what they currently came in with. Now we know what we're changing. It makes it easier for you and every other doctor that's working with you guys as well. So you want to ask them if they've had any previous surgery. This can have an effect. Previous surgery can sometimes answer a lot of your questions. And then you want to get all of the information if they've previously been discharged. So if they've previously been admitted, in the hospital, you want to ask them, why did you come into hospital? And you want to read the previous discharge letters over on the system as well. So, you want to gather all this information so that it will help you build a picture and help you make a diagnosis. Now, no one's expecting you to know straight away what's wrong with the patient. I mean, for example, someone's coming with a bit of a cough, could be a number of things, could be an exacerbation of COPD if they have it, could be pneumonia, could be an asthma flare, for example, could be a number of things, but you can write down what you think it could potentially be. So you can list out your differential diagnoses, but it's okay if you don't know. No one's expecting you to know as an F2 straight away what's going on, but you should have an idea of what it could be, and you need to show you're working out essentially. So my top tips. So make sure you take a detailed history. Make sure you ask them about any other systemic symptoms. So they may come to you saying, oh, doctor, I've got a really tight chest, and you're thinking already, maybe they've got, a heart attack's going on. So you're thinking in your head, ECG, blood tests and all this. But what if they tell you, actually, I've got a bit of a burning pain. Oh, hang on a minute. Maybe this tight chest isn't related to the heart. It could be gastro-related. It could be a bit of epigastric pain. So you want to take a detailed history. So after you've asked them about all their main symptoms, then move on to, have you experienced any nausea or vomiting over the past 24 hours? Or do you experience any tingling, burning, stinging sensation when you go to pass water? How are your bowel habits? Are they normal? So you want to cover every single base so that when you present your case to the consultant, you can say, I definitely know it's this because I've ruled everything else out. Always want to ask about past surgeries. So many times people will clerk and will never ask this question because it's not on the system. They may have gone somewhere else. Something that I'm noticing a lot now in modern practice is people will go privately for theatre work. So when they come to the NHS, it's not on the system. So we don't know that they've had this surgery in this place or this surgery abroad. So you want to get all the information. Any allergies or reactions, not always the allergies and reactions are stated on the hospital documents or even on their system. And sometimes they can tell you themselves that, oh, I'm a bit sensitive to codeine actually, or last time I tried penicillin, I had a bit of a reaction. You want to make sure you know this before you prescribe anything to any patient. And always ask about previous admissions. So have you been in the hospital before? What was the reason? Always remember to write your drug chart. You don't want to do all this beautiful clerking. You've answered all the relevant questions. You've written the drugs out in the clerking booklet, like you've asked the patient about their medical list, but you forgot to actually prescribe their medications. So when you clerk a patient in, even if they tell you, oh, doctor, I take metformin every day, twice a day, in the morning and in the evening, I've got the medication with me, I'm happy to take it by myself. No, when they're in hospital, it is your responsibility to prescribe their normal medication, and it is then the nursing staff's duty to dispense it. So while a patient is in hospital, any medication they receive must be documented in the drug chart and must be given by a nurse. So even something simple like paracetamol, you have to prescribe it, nurse has to give it. They can't just take it out of their handbag and take it. So that's why you need to prescribe all the medication on a drug chart. So this could be electronically prescribed. They use a system called EPMA in most hospitals. In some hospitals, they still prescribe, via hand. So you have to write it on a drug chart and prescribe all the medication. So you write, let's say a patient takes furosemide every day. You'd write furosemide, 40 milligrams. When did it start? H for home. So we know that this is something that started prior to hospital. You sign it, you write your name, and then always indicate what time you want the patient to have it. So 8 a.m. or, 10 p.m. It's always 8 a.m. for the furosemide though, just for you guys to know. Enoxaparin. I had no idea what this was when I started working, shamefully, but in England, everyone's really concerned about blood clots. And especially being in hospital, blood clots is an amazingly high thing. I recently just did an audit on it, and the amount of patients that end up having a DVT or a PE during admission is insane. So to prevent that, we prescribe enoxaparin to every patient. So 40 milligrams if they're above 50 kg and they have a normal kidney function. It's 20 milligrams if their kidney function is less than average. So it's, it's not within the baseline, it's really low, their EGFR, or if they're less than 50 kilograms, is when you prescribe 20. So That has to be given every day at 6 o'clock in the evening. It's the same throughout all hospitals in the UK. Some people call it enoxaparin, which is the actual medicine's name, or it can be called Clexane, which is what the pharmaceutical company have called it. But always remember to prescribe that when you're admitting a patient. You don't prescribe it if your patient is going to go to theatre that day. But what you do write is you write it on the drug chart and then you put an X on the time that it's supposed to be given at. This shows the consultant that patient, that the doctor clerking it was aware that she needed to prescribe the enoxaparin, understood that the patient was going to go to theatre, that's why she omitted the dose, but it's ready for the next day for when the patient needs to have it, so that the next doctor, or even if it's you, doesn't have to get called by a nurse. Oh, can you please come prescribe enoxaparin? It's already done. So always remember enoxaparin. It's really important. And that's why patient weight is really important, because it's not just important for when prescribing enoxaparin, it's important when you're prescribing paracetamol. Patients under 50 kg are not allowed to have 1 gram of paracetamol. It has to be 50 instead. 500 milligram. And you want to make sure you know that, because nurses love to pick up on the drug chart when you've made an error like that. And if you have really lovely nurses, they'll be happy to flag it up to you and be like, oh, sorry, doctor, I think you might have done it by mistake. But you don't want to be in an off chance where the nurse didn't realize the patient was underweight, you didn't realize the patient was underweight, and then we've given the patient too much paracetamol, and we keep doing that, and we keep doing that, and we keep doing that, and then we put them into a liver failure or something. You don't want to do that. So you need to always make sure you have everything right, because the first person it's going to come to is you. Why did you prescribe it when you should have checked that the patient was underweight? And then always remember to write your blood results in the clerking booklet. Even if you're waiting for the blood results to come, put it on your jobs list to go back, find the blood results and write it in the admission booklet. That is so important. And this includes blood gases as well as normal blood results. So how to write a discharge letter is what we're going to go into next. So why did the patient come in? So every discharge letter is written differently throughout the country. So unfortunately, I can't give you guys like a set standard of what it is you've got to write and how to write it, but this is the main information. So when I worked in Norfolk, it was really different. We would write down the patient information very simply, like Mr. Smith came in on this day, this is what he presented with it, this is what's happened during admission, this is what we want you to do as a GP, any further questions, that's it. But in other hospitals, so the hospital I work in now, the first question they ask is, did the patient die on admission? And you put no. And then it'll ask you, was there any medication changes? So this is why the drug chart is so important. And then you write everything else. But the main gist of the discharge summary is, why did the patient come to hospital? What was your diagnosis during the admission? So what did they come in with? What we diagnosed them with? And then what was the story? So Mr. Smith came in with right iliac fossa pain, diagnosed with appendicitis, then the story. Patient presented with 2-day history of abdominal pain, started centrally, migrated to the right. Patient experienced some nausea and vomiting, no bowel habit changes. Patient experienced some temperature and some rigors, no urinary symptoms, no chest symptoms. And then we operated on him, removed his appendix. Patient was given, 48 hours of antibiotics. No further follow-up needed from surgeons. Then do we want the GP to do anything? In this case, no. So no GP follow-up needed. And then in some cases, there'll be a section that says, explain to the patient. So then you'd write, then this is when you've got to not write in medical terms. Now you need to write it in layman's terms so the patient would understand. So I always go with, you came in with some pain in your tummy, located in the right side. We diagnosed you with appendicitis, or, we stated that you had appendicitis. We took you to theatre. We operated on you. We removed your appendix. We gave you some antibiotics. You've now completed them. Should you have any medical concerns, please contact or seek medical advice. That line is so important. Should you have any medical problems or any medical concerns, please reach out and seek medical advice. That's your safety netting. Safety netting is so important in the NHS. And again, this all comes down to medical legal issues. You have stated to the patient that, look, something could go wrong. It's not, something might not even happen at all. But in the off chance something does happen, we are telling you to go to seek medical advice. Because if you don't write that line down, and I don't know, let's say he has his wound bursts or something, as silly as it may seem, the patient will obviously go to seek medical help. But in the off chance, let's say a patient doesn't, they will say to you in court, you didn't write on there to go seek medical advice, or you didn't safety net your patient that they could come back, or you didn't explain to them what could go wrong. Always remember to safety net yourself. You're covering yourself and you're covering the patient. And then obviously you add any, if they do need a follow-up, for example, then you'd write down, follow-up in so-and-so's clinic. And at that point, you don't need to worry about what time or the date is of the clinic, because that's the secretary's job. They will go and find that out. So any discharge letter you write, if it's for a surgeon, for example, their secretary will receive a copy of the discharge letter, and then she'll sort out the appointment and she'll schedule it with the patient herself. But if it's like a medical thing, same thing applies. They'll figure out with the right secretary when the appointment is. So don't worry too much about that. And then you write any medications. So if a patient stays in hospital more than 48 hours, then you have to prescribe all their regular medication as well as new medication we're going to give them. And we send them home with it. If a patient hasn't stayed more than 48 hours, you don't need to prescribe the regular medication. You can just prescribe the new ones. That's it. How to write a referral. So first of all, you need to decide who you're going to contact. And once you've decided that, you want to give them your contact details so that they can contact you. Always remember, what is your question? So if you're sending a referral to somebody, what exactly are you asking them? So let's say you want gastro to see a patient because they keep having continuous vomiting and you're not sure where it's coming from. You've done some scans, you're not seeing anything, and you don't know what to do. Don't be like, please can I have a gastro review for my patient who keeps vomiting? First of all, that's going to get rejected straight away. No gastro consultant nor registrar, because they don't understand what your question is. Because the patient's vomiting, give them some antiemetics. You need to explain and give them detail, but also be very direct with your question. So you could say, please can you review a patient, 72-hour history of vomiting, not affected by taking antiemetics, now it's just bile, please could you review the patient and give us a plan? That's a straight answer. They already know what's going on. You've given them a quick snapshot, and then you move on to why the patient got admitted. So patient presented on Tuesday, came in with, let's say deranged blood sugar levels. They have a background of type 2 diabetes. That's it. And also you need to consider what is appropriate when you're referring. So something that you guys need to remember is when you guys come out of med school, you guys refresh your knowledge, even though you might feel like a bit wobbly and you're already overwhelmed, you've come from another country, even though, medical knowledge is the same wherever you go, remember that. But still, consultants, once they get to their level, they are very specific and are very knowledgeable, but only on their speciality. So they might ask you to send a referral for something that's probably not really necessary, or you may yourself feel like you need to refer a patient to another specialty that's probably not very necessary. So you always need to think, is this referral appropriate? What are we going to achieve from this? What are we expecting from this? Because you don't want a referral to be rejected, because your referral being rejected causes more problems than you can imagine. There will first be a question of, why did you refer? What did you expect to gain from this referral? Who did you discuss with to make this referral? And so forth. So you just want to make sure that you have covered all your bases. So you want to make sure you understand why you're sending it, what the referral is for, what your question is, what you expect to achieve. Because sometimes the consultants may ring you directly and be like, can I get a bit more background? Your referral didn't have this, this, and this, or I just want a better insight. Can you please give me more information? So make sure you know everything before doing a referral. So we're going to try one together. So I've got a little example. So let's say, for example, you are on an orthopedic ward and you really need a surgical review. Patient's admitted with a right neck of femur fracture. That's what NOF means. And they were operated on the 16th and they haven't had their bowels open for 6 days. So we've stated why the patient's been admitted. So there's different formats of how to write a referral, but this is like just the background for you guys. So we've explained that the patient's come in with a NOF when they've been operated on. What's our question? So bowels have not been open for 6 days. We did a PR exam. There was no feces, no blood, no evidence of hemorrhoids, but the abdominal X-ray ordered and reported showed that they had bowel obstruction. Please can you review and give us, review the patient and give us a management plan. We write a background of patient's got atrial fibrillation and type 2 diabetes. Thank you. That is short, a quick snapshot of what's going on with your patient. You've made it very clear that you want them to review the patient. You've explained why you want them to review the patient. You've made it clear what the background and history is. And now the surgical registrar that's going to read your referral is going to be like, okay, so bowel obstruction, I clearly need to intervene, but now I also have some information about the comorbidities, because they need that information if they want to know if they're going to operate or not. So yeah, that's just a little like example of how to write a referral. So I said I'd go over you guys really quickly about the news score. So the news score is something that nursing staff love to use, and so do we as doctors. This basically is what the NHS uses. So the news score is done on average on every patient about every 4 hours. Unless you're really concerned about patient, then they do it every 2, can be even every 30 minutes on some patients. And it's scored. So let's say the patient's got, so you want to make sure you're always in the middle at 0. You want to make sure your patient's always at 0. But let's say your patient has got a drop in their blood pressure. So they're scoring a 2 for that. And they need oxygen. So they're going to score a 2. And their, let's say their respiratory rate has gone up. It's gone up to like 21 to 24. There's another 2. That patient is now scoring a 6. The nurse is fully aware she needs to come and ask for help. So she will immediately contact the doctor that this patient is scoring a 6 on the news score. And the first thing you're going to ask is, can you please tell me what the patient is scoring on? And then then she'll tell you, oh, it's this, and it's this. And you're going to be like, oh, okay. Then you want to look at the trend. Has the patient always been having a low blood pressure throughout admission? Is this their baseline? Because it could just be their baseline. You want to look at, oh, okay, so has the patient always had really high rests? Or was it low before and then it jumped up? Or was it even higher before and it's come down? Does the patient always need oxygen, or is this a new thing? And you just want to be able to work it out. This helps you decide how sick your patient is, but it also helps nursing staff to alert you when there actually is something going on. So it's really important, but you want to make sure you understand it, because we don't really learn about this when we're in Bulgaria, unfortunately. And in England, this is something that they really do like hammer into their med students to make sure that they are aware of it. So just make sure you guys come into grips, you learn this really well, because they do talk about this on your interview as well when you go on to apply for jobs. Thank you for listening. Does anyone have any questions?
So perfect. Thank you so much for that presentation. That was so good.
Thank you.
It was really informative, actually. So I was making notes myself. So I have I've got a question here, actually. So I've got a question from Mr. Singh, and it says, do you ever get overwhelmed by the number of duties you have?
So I think at the beginning, when I started, I wasn't very overwhelmed, because when you start working, they kind of like ease you in. So they won't be like, oh, it's your first day, go see a patient. They'll be like, oh, it's your first day, shadow someone. Although there are days when you have too many patients. Like last week, I currently work in orthopedics, and I was the only person on my team, and I had like 30 plus patients, and that can sometimes be overwhelming. But if you have like a plan, so always carry a piece of paper with you, always make sure you write down all your jobs and prioritize what's more important and what's not. So nursing staff, for example, will tell you that discharge letter needs to be done, and that's what's important to them, and you've got to respect that. But if you've got a patient who's like, I don't know, going to theatre, or is got a really high news score, or is desaturating or something, that's more important than the discharge letter. So then you rearrange your list and you reprioritize. So yeah, it can be overwhelming, but it's not at the same time if you learn how to prioritize things correctly.
That makes complete sense.
Sorry, Justin, there is always support. So, don't think to yourself, guys, that, oh, I finish at 5, I have a really long jobs list, I need to finish it all by 5. That's what the twilight doctor is there for. So anything really urgent, you can hand over to them. And anything that's not urgent, don't hand it over to them, and prioritize it in your mind. Can it wait till tomorrow? Or I'll just stay behind myself for like a couple of minutes to finish it off.
Perfect. I have a question. Is FY2 or 1 paid foundation year training?
Is FY2, sorry, what?
So if FY2 or FY1, so foundation training paid. So I'm assuming
Yes,
the
it is.
question is that do you get paid?
So yeah, so you do get paid. F1 is a little bit less than F2, but yeah, you get paid for it. Not like in Bulgaria where our 6th year is part of our degree. In England, they are paid.
Perfect. I have a question. How do the British trained doctors relate to you as a Bulgarian trained doctor?
Well, you're all doctors, aren't you? So you relate on that level. Your medical knowledge is the same, guys. I think we all have this stigma that we've studied in Bulgaria, we're probably not as smart as they are, or probably don't know as much as they do. In actual fact, you'll find your knowledge is the same, and even if not better sometimes. Like, I'll give you a perfect example. The anatomy you guys learn in Bulgaria, way more than what they learn in England. And that's a positive. That's actually a big plus sign. There are lots of things you can relate to those guys on. Maybe your exam style is probably not the same as theirs, but you shouldn't struggle with that. But don't go in with that notion of, oh my God, I don't know as much as they do. You do, trust me, because I went in with that, and that constantly like used to scare me. And then you start working and you realize, actually, I know what I'm doing, so you'll be fine.
I guess just have a little bit of faith in yourselves. You know, you've
like that.
years.
I think that definitely is a big thing. Like, be confident, but don't be too confident, because sometimes that can be dangerous too.
Yeah. Do you ever feel that you are jeopardizing family or social life when you work twilight or night shifts?
Oh, that's an interesting question. So I hate nights, and I have nights coming up next week, and I definitely will say nights are horrible because it messes up your whole sleeping system and everything. Yeah, sometimes it does, because you'll miss things, but then I guess it's the job you guys have chosen to do. So you're going into it, you kind of know that your time is not always going to be yours, and that's to be expected. Twilights are a little bit more flexible. So for example, let's say you're going to start at 5 because your twilight starts at 5. You can go out for brunch with your friends. You can still see your family members, because let's be honest, you're going to finish work at midnight. By the time you get home, it'll be 1. That's kind of normal. Like, most people kind of sleep around about midnight time anyways. It might stretch you a little bit. You get to wake up late. So it's how you adapt and how you adjust your pattern and what you're doing. But you'll find time. But I will say there will be times where you will miss like family events or something, but it comes with the job.
I think that's something that you'll find in a lot of other jobs as well.
Yeah, it's true.
All careers kind of require commitment.
Yeah, it's true.
So I think that's not just in medicine, but maybe there will be times when it might be a bit more, or things like that. Yeah, especially if you have to work a bank holiday or something.
Exactly. But if you work a bank holiday, guys, you get an extra holiday, so they'll give you an extra day in lieu, so you can use that whenever you want. So my tip would be, try and work as many bank holidays as you can. That's what I do, and then I get extra holidays, because otherwise you only get, what is it, like 28 days of holidays. But if you work, like, let's say 3 bank holidays, you then get an extra 3 days to do whatever you want with them, and then you can move them around yourself. So
that's really good advice, guys. So make notes of that. That's really good advice. I have this is a cool question, so I'll ask it. Is it taboo to hand over your jobs list?
Oh, good. That's a really good question. So some things you can't hand over. For example, don't hand over, can you chase my bloods if it's not important? Like, if they're just routine bloods and you're not concerned at all about the patient, you're not worried about the hemoglobin, you're not worried about inflammatory markers, you're just doing routine bloods. Yeah, you can say, can you chase them? Then don't be like, oh, can you go write them down in the book as well? No, they've chased them, they've looked at them. If they feel like they need to act on them, they will do it. But if it's not necessary and you don't think it's necessary, don't hand it over. Discharge letters, never hand over discharge letters. That is like a big no-no. If you're the twilight doctor coming on and someone tells you at like 5 p.m, can you write a discharge letter for me for someone that's going home tomorrow? Unless it's like really urgent and you've been super busy all day, it's kind of not polite to be given over something like that. But yeah, 100% hand over if you need to, because at the end of the day, when it's 5 o'clock, it's your off time. So yeah, at the start, everyone stays a bit late, everyone wants to be diligent, but your time is your time, guys, because you're going to be back again tomorrow and you don't want to burn yourselves out. So yes, there are some things you can't hand over, but always think patient priority is more important. So if there are bloods that are, like hemoglobin is dropping and we're concerned, 100% hand it over, but don't hand over. It's one of those things you will start to realize once you're working and once you see your patient, what you think is acceptable to hand over and what's not.
I guess I think that comes with the job, doesn't it? Like you kind of like build that slowly.
Yeah, but I mean, like let's say, but don't ask someone like out of hours. Like let's say they've finished work at 5 and the twilight's starting, and you're like, oh, can you ring microbiology to ask about antibiotics? Because out of hours in most hospitals, the microbiologist isn't there, so then you're going to be speaking to someone directly at home. And if it's not dire, like they're already on antibiotics, you're just querying whether you need to take them down or something like that, or take them off of antibiotics, I think that can wait till tomorrow. But you have to make that judgment call yourself on your patient and decide, is it important or is it not? Because it could be if you're concerned about C. diff and you want to make sure they don't have too many antibiotics, for example.
Yeah, that makes sense. I have a question here. How long did it take you to register with the GMC?
So I handed in so as soon as I graduated, I got all my paperwork and my degree stuff, I think in like November, December time. I started to do the process and the application. It took about, I would say, this would have to be like the longest month of my life because I was constantly scared that I wasn't going to get accepted and there was a whole Brexit thing. But I got my license in January. So it was about a month and a bit, roughly. Yeah, but it can vary and it depends as well because I was like a backlog because of COVID was going on. So some people say it's really quick, some people say it's really long. It's like dependent. One piece of advice I would give is ring. Don't have any shame. I used to ring the GMC like probably every 48 hours to be like, is there any update? Is there any update? Is there any? And then eventually they get tired of listening to you being on the phone and they'll just process you through. Is what I did. But always make sure you've got all your documentation ready and you have copies of everything as well because they might lose something or something might not be right. So the earlier you start, the better.
Perfect. Because you graduated two years ago, was it? Or 3?
2, yeah, 2.
2 years ago, yeah. So I guess that that was literally when Corona was happening. I remember it was right in the middle.
Yeah,
so.
literally and it was just a mess.
Yes, I don't think it's as bad at the moment, but yeah, about 4 to 6 weeks is rough. Yeah. What they say, isn't it, that it takes to get that done. Okay, I'm just going to quickly. So there was a question here that I will answer. It was your med school in Bulgaria on list with the GMC? So all the universities that SME works with are all accredited by the General Medical Council and the GDC as well, which is the Dental Council. And that means that Simren's was as well, because if Simren's wasn't, then you wouldn't have been able to get your license, I'm assuming, right? You have to be on the GMC list. Yeah. So yes, so it is any university that you do have, queries about, guys, you can just go on the GMC website and type in the name of that university and it will come up with the list. So you can see which ones are accredited by the GMC. So give that a go if you ever have any questions. This question was, I think we kind of answered it, but I will ask you, was there a big learning curve when you started to work? I think you kind of answered it.
Yeah, definitely. Because even though you have the medical knowledge from med school, you don't understand how to apply it. And every system's different. So look, I'll be honest with you guys, I am born and raised in England and I found it difficult. So something for me, for example, it was like my 2nd or 3rd day and I had a patient, I was working in acute med, completely fine, so I was going to discharge them. I discharged them, wrote the discharge letter, did all the stuff I needed to do, and then I went and had lunch. So I was kind of expecting when I come back, they'd be gone. What actually happens is in England, there's a thing called package of care. So if it's not deemed safe for a patient to be discharged, they will not be discharged, no matter how much you kick and scream, no matter how well they are, because it's safety and care of the patient. So that's something I found really difficult to come to grips with because we don't have package of care in Bulgaria. Once you're well and you're done, you're out the door. So that was something I had to get my head around. Using their systems, that kind of takes a while. You kind of feel a bit disorientated because blood results come online. Every hospital system is different. So I've changed trust, working in Norfolk to working in the Midlands. And that was a bit of an adjustment as well. Every hospital has a guideline for every little thing. So if you don't know something, just check the guideline out. So it's a learning curve on that way, but guys, definitely you have the knowledge. That's not what I cannot stress on that enough, is don't think to yourself that I've graduated in England, I don't know how, I've graduated in Bulgaria, I don't know how it works. You do. Just little things though, like, for example, that conversation I told you guys about when you're ringing a family member up to confirm their date of birth. It's not something I knew, it's something I learned from watching another doctor do it, and then realizing that, oh, hang on a minute, you have to do that every time, because consultants sometimes are standing there and will ask you, did you check that it was the right person you rang? Or there's some times where we've got into issues with, there's a brother and sister, they're fighting over the care of their mum, one's got power of attorney, one doesn't. You need to be careful, you don't want to get caught in all of that. Just things like that. But otherwise, you pick up it very quickly, doesn't take that long to adjust, you'll be fine.
Yeah. And that's the same as us, like, when the GP calls us, they always ask you to confirm,
Yeah.
So to kind of maybe think of it as like, if you were a patient, how do things go? How does the doctor treat you? And then you always kind of keep that in mind. So I had a blood test recently. When the doctor called me, they asked you to confirm your address.
Yeah, exactly.
So obviously, guys, try and, like, put yourself in the patient's kind of shoes. And I think when someone was mentioning the package of care, like, that is basically, is it safe for the patient to go in? So for example, the patients come in with a fracture and they live all on their own, and imagine they're a geriatric patient, and that patient's not going to be able to take care of themselves once they go back to their place. You can't really discharge them. You need to create a package of care, and there are people in the hospital that will do those things, that will come in and do an assessment. So that's kind of how you have to think. You have to think in the long run, that if that was you, or if that was your grandma, if you were in that position, how would things kind of go moving forward? So I think that was a really good point to make. So yeah, I think we've answered as many questions as we could, because it's 7 o'clock now, so we're kind of running time. Thank you so much for joining today.
Thank you for having me. I've really enjoyed it.
Yeah, and honestly, it was nice to see your face after so long.
Yours too.
Hopefully I'll see you soon.
Definitely.
And guys, just wait up, because I've still got a bit of the presentation to do, but we're just saying bye to Simren, and just a thank you so much.
No worries. Bye.
See you soon. Bye. Okay, so now we will be doing the scholarship prize. Okay, so for you guys that don't know, this is what we offer. SME offers a grand total of 45 scholarships to 2022 applications through the extension of the SME sponsorship program. So for all of you guys that did miss out in November 21, now's your chance to become one of our lucky winners. From January to September 2022, we'll be providing 5 scholarships each month to prospective students applying through SME. So these scholarships are valid for 50% of the tuition fees for the entire duration of the undergraduate or graduate medicine or dentistry courses. A lucky draw will take place at each of our monthly symposiums, like I've mentioned, and 5 random winners. So I'm going to do that right now. Let me just pull it out. So I have already added everyone's names in here. I've added 5 random names to pick. So guys, get ready. Here we go. And these are our 5 winners. And I'm just gonna copy and paste it into my presentation, just so you guys can kind of see clearly what the names are. And I'll make it a bit bigger. So guys, these are the names of the students that have won the scholarship. And what we will do is we will send you an email. So all the winners will get an email, and then we will proceed further that way. So, okay, partners. So I want to say a big thank you to our sponsors, Lecturio, an all-in-one study resource for medical students that combines learning science and medical education into one easy-to-use platform. You can access a variety of high-yield medical videos, lectures, take a closer look at the human body with scientifically accurate 3D anatomy models, test your knowledge and assess your learning progress by answering interactive quiz questions, prepare for exams using the most advanced question bank available. Even better, all of Lecturio's exam-style clinical case questions include text and video answer explanations. So www.lecturio.com. Feedback form okay, is there's a captcha, guys, just here. So if you scan the captcha, you will be forwarded a link to our feedback form. And with the feedback form, if you fill it all in, you will actually get a discount code for Lecturio. And also, one of you guys who have filled the feedback form will also get a free, I think it's 6 months, it's a 6-month subscription to Lecturio for free. So please, please, please make sure you fill in the feedback form. It's just about your details, and you'll also get the Lecturio discount code, and one lucky winner will win 6 months of Lecturio subscription. So I just want to say a really, really big thank you to everyone, who did tune in today. I really, really appreciate that. And hopefully I will see you guys the following month. We'll have a new topic, a brand new topic. And also we'll have 5 new lucky winners. So see you guys then. And I hope you all enjoyed the presentation. So thank you so much.